So as I mentioned before, healthcare improvement, quality improvement, was in its infancy when we had the three pillars of quality improvement: structure, process, and outcomes. What we see now today in oncology is that it's really in its adolescence. We see that there are many stakeholder organizations with the best possible of intentions who've contributed to the quality improvement space. They've developed separate measures by which we benchmark quality, but what's happened is that we have a barrage of new quality measures. There are many organizations, there are many measures. It's very difficult then, because of the hodgepodge that's been created, to have parsimony in a quality improvement strategy. Not having parsimony in a quality improvement strategy is challenging. You need to have only the measures that you need, exactly what you need, so you're able to make apples to apples comparisons. Because you may be in one individual practice and you may have 10 different alternative payment model contracts, and they may be benchmarked on different measures of quality, and so even within your own practice you can't make apples to apples comparisons between those different contracts for quality improvement. So it's a major limitation, the fact that there is not parsimony in the data systems. In addition, other organizations, other non-oncologic subspecialties have developed parsimony in how they have quality measurement. Cardiology, internal medicine, CMS and AHIP and patient representatives and physicians have gotten together and sort of agreed on general standards by which they'll measure quality, and that's been really helpful. I would say oncology has not gotten there yet, and so we remain in our adolescence. I think that the other big challenge that we have, in addition to the multiple measures and multiple stakeholders that have not aligned and consolidated quality measures, is how we report on quality improvement. So if you look at the infrastructure systems to report on quality improvement, there are two basic mechanisms. Either you try to report through structured data elements that you typically would find in an electronic health record, or you pay someone to abstract the data from the chart, usually by reading notes and taking down information and abstracting it. So there are problems in both systems. One, if you look at electronic health records, most electronic health records are not yet sophisticated enough to really capture well quality metrics. Even if they are sophisticated enough, which is only a small number, it takes additional time for physicians to enter in that data if it's not someone else from their team that's entering in that data. What that means is when I sit with a patient with breast cancer and talk to them about their new diagnosis, I get to spend less time face-to-face with them, and they see my back because I'm facing a computer, because I'm doing more data entry. So it's challenging because even though doctors can enter that data, if you have the capability within your electronic health record, it decreases efficiency of practice and it decreases productivity. So it's not an efficient way to do quality measurement. There's also limitations in the other system, which is abstracting. When you have an individual that you abstract, first of all, it's an FTE for the practice. It's a full-time employee for the practice that they have to pay, usually a nurse. Second of all, there's some bias from who's reading it. There's variability between the way physicians dictate. There's inter-rater variability from how an abstractor is going to query those records. So there are challenges in both systems. We need to evolve and mature to have more integrated electronic health record systems that sort of have less redundant mechanisms to capture these metrics moving forward.